pleasure of introducing Dr. Jacob Calvert today. As most of you know, he's a current third-year resident in the program and is soon to be chief resident. He was born in Provo, Utah, graduated with his undergraduate degree at an unnamed university down south, and then went on to get his medical degree at the University of Washington, and we were lucky enough to draw him back here again for residency. You know, Jacob has won numerous academic and teaching awards in his career thus far, and I think you would all agree that he has a reputation for being a very efficient, meticulous, and evidence-based physician. And so it was really no surprise to me when he suggested that he apply those same principles to the topic of cesarean delivery, the most commonly performed major procedure in the United States, and a procedure which he has done almost 300 times so far in his residency already. Did you know that?
Really?
Yeah, I checked with Natalie. So without further ado, we're going to let Jacob talk to us about evidence-based cesarean.
On and okay? All right, so I want to talk about evidence-based cesarean section today, and this is a topic that I've actually been semi-interested in since my intern year. And I think that all of us have probably thought about this at some point, that you're doing C-sections, especially as an intern, and it seems like you finally get down one technique, and then you're with someone else, and they do something completely different. And then, at least for me, went down to IMC, and it's all these new things again, and trying to figure out what is the right thing? What should we be doing? If someone just left it up to me and said, how do you want to do this C-section? What would I do? So we're going to talk essentially about three things today. Very briefly, the history of the cesarean section. Then we're going to talk about something called package techniques, which will make a lot more sense in about 3 minutes. And then we're going to do a step-by-step literature review, talking about step-by-step going through the C-section and what should we or shouldn't we do. So I handed this paper out, and if you don't have one, it will probably make it easier if it's in front of you because it'll just be easy to look at as we go through. And I'm going to talk about it quite a bit. First, let's just talk about the history of C-sections. So on this paper, we have 4 essentially different techniques. And even before this first technique, which was fan and steel, was described in the late 1800s, lots of C-sections were done before that. The mortality rate of the cesarean section between 1870 and 1890 was about 75 to 80%, so extremely high. In 1896, fan and steel introduced his incision, and we all know what the fan and steel incision is. After that, it evolved into what was called the fan and steel technique. And so what we have on here going down is the steps of the C-section, and then what the steps would be using a fan and steel technique. There were, between 1896 and 1954, there were lots of different techniques that were described. Some of them we would never use now. One of them, to decrease infection. The mortality then was because of infection and bleeding. And so one of the techniques was described was they would do the delivery and then they would exteriorize the uterus and close the skin around it and leave it on the abdomen for 2 weeks and then return it to the abdomen 2 weeks later if there was no evidence of infection. They had all these different ideas. How can we make this, how can we cut down on the mortality during a C-section? In 1954, Joel Cohen described a different incision. So the Joel Cohen incision was a little bit higher than the fan and steel incision. It's on my next slide. And from that evolved the Joel Cohen technique, which is different than the fan and steel technique. In 1983, there was a modification of the Joel Cohen technique, which was developed by Michael Stark, and it's called the Mizga-Vladik technique. It's named after this hospital in Jerusalem where he developed it. But it's a different technique. And then in 1995, there was a publication by a man named Marco Pelosi in the United States that developed his own technique, the Pelosi technique of doing a C-section with different steps that they would go through. We're going to come back and talk a lot about this and what these things were, but one thing needs to be perfectly clear, and that is that there's a difference between a Joel Cohen incision and a Joel Cohen package technique, which is what's on here. So the Joel Cohen incision is described as a straight incision. This doesn't quite look straight, but it's a straight incision 3 centimeters below the line that joins the anterior superior iliac spines. It's about 2 centimeters higher than the traditional fan and steel incision. The idea was that there was less bleeding and that it was easier to dissect the rectus muscles if you were a little bit higher up. So the reason I have this slide is just so that it's very clear as we go through. There's a Joel Cohen incision and then there's the Joel Cohen package technique, and that they're 2 different things. It would be possible to do a Joel Cohen incision and then have the rest of your technique be more like a fan and steel technique. The early studies that looked at C-sections, and we have lots of them, looked at comparisons of these different package techniques. So if you take the one on the far left side, it's the Mieszko-Wlodek technique for cesarean section compared to a fan and steel. This one is a modified Joel Cohen compared to a traditional C-section, or the Pelosi type compared to a traditional C-section. So what they were doing is they were comparing this entire C-section all the way down the line. If we do everything like fan and steel described, or like it was described after he introduced his incision, what happens? Or all the way down the Joel Cohen side. These papers are sort of interesting to look at. So we just pick one of these papers and we look in the paper. Now, the details of this aren't important, but what they described was a complete package. So here's all the steps. You have the skin incision. How do you go through the fascia? How do you dissect the rectus muscles? Saying, this is my technique, and it's different than the traditional fan and steel technique. So look at the paper in front of you. Maybe easier to read than what's up there, but if you look at the fan and steel technique, it's generally a sharp dissection. So as you go down, a fan and steel incision, sharply dissect the subcutaneous tissue, sharp fascial entry, sharp fascial extension, sharply dissect the rectus muscles off, sharply enter the peritoneum. You move over one to the Joel Cohen technique, and it's all of those things but blunt. So really, what the difference was is they moved from a sharp dissection to a blunt dissection. There's been lots of papers published on this. So this is a Cochrane review from 2008 that looked at comparisons of different package techniques. So not steps, but the entire C-section package. Let's just look at what they were looking at. So they identified 23 studies that compared different techniques of cesarean section. So this describes what essentially they found in these different studies. So there was some variation in the detail of techniques, meaning when they looked at the different types of packages, there were subtle things that were different. But so the authors, several different variations defined by the authors Joel Cohen, Mieszko-Wlodek, modified Mieszko-Wlodek. All of these methods were based on the surgical technique that was described essentially by Joel Cohen, which is the principles developed by Joel Cohen, blunt separation of tissues along natural tissue planes using minimal sharp dissection. And so for the purposes of this Cochrane review, they grouped all of those together. Essentially, the Cochrane review is a comparison of blunt and sharp. What's better? Should we be doing blunt dissection? Should we be doing sharp dissection? Let's look at what they found. So as they went through and they looked at all 23 of these studies, the Joel Cohen-based, or the blunt dissection, was associated with less blood loss, shorter operative times. There were less fevers in the Joel Cohen or the blunt dissection group, lower duration of postoperative pain, and a shorter time from skin incision to delivery of the baby. So to sum up what they saw, blunt dissection or the Joel Cohen-based techniques had less pain, less fever, less blood loss, and shorter surgery. So just looking at this and reading through it, sounds like, gosh, we should be doing a Joel Cohen type surgery. And I was thinking about it as I was looking through this. There's lots of things from this Joel Cohen surgery that we do and things that we don't. So if Joel Cohen can have his technique, why can't I have my own technique? Why can't all of us have our own technique that we use, right? No one's forcing us to pick one row and go all the way down. We don't have to just choose a column. We can pick and choose what parts of this we want to do, what we think is best. So the goal for the rest of this talk is to look at each step of the C-section and find randomized controlled trials that compare just that step. So the first one is the skin incision. So if we're going to compare that, we want to find randomized controlled trials that look just at a fan and steel incision compared to a Joel Cohen, and everything else in the C-section is held constant. So we can decide which of these is going to be better. And I'm going to go through, we're going to do a literature review. We're going to go through the primary literature that describes each of these steps. And at the end, I'm going to show you kind of what I think I would do after reviewing all of it. But we can all come up with what we think would be the best. So as we go through this, mark what you think, what you would do. Your paper will look like this at the end. We can pick and choose, and we can come up with what the best technique is. Before we can talk about the C-section and those techniques, we have to start with the antibiotics. So we're going to go start to finish. And one point that I didn't make at the beginning, I'm not talking at all here about the decision to perform a C-section. We all know that there's benefits to a vaginal delivery. So we're starting at the time where we've decided to do a C-section. That would be another talk. But once we've decided, these patients need antibiotics. This has been well studied. So there have been more than 80 randomized trials looking at antibiotics specifically for C-sections, and we know that we need them. And ideally, they should be given before surgery, 30 to 60 minutes before surgery. It's okay to give it before delivery of the baby. It doesn't mask infection. Antibiotics before surgery is the ideal way. What about our skin prep? So we know that we should be prepping the skin with something. This is what we use here, the ChloraPrep. Has this been studied? Yeah, it has. We know that skin prep is good, and the different types of skin prep have been looked at. So this was an article from the New England Journal of Medicine in 2010, and it looked at a chlorhexidine-based prep versus a typical iodine prep, and which is better. It was a big study. They had about 400 patients in each group. It was well randomized. And what they find? They found that the chlora prep or the chlorhexidine type prep is actually better. So when they looked at total infections, it was 9% versus 16%. So I think that as we're prepping, now we use this here. If you're in the middle of Africa and you have nothing or you only have iodine, definitely prep with something. But if both are sitting there and we have a choice, there's some evidence that a chlorhexidine prep is actually a little bit better. What about the drapes that we use? This has been studied too. So adhesive drapes versus non-adhesive drapes. There were 2 randomized trials that looked at an adhesive drape compared to a non-adhesive drape and found that there was no benefit to an adhesive drape. So the adhesive drapes were developed thinking that it would stay in place and it would prevent infection. And these 2 studies said there's no benefit. It's not preventing infection. And then there was a meta-analysis that came out in 2005 that combined both of these. And there was almost 1,000 patients in each group that actually showed an increase in wound infections with an adhesive drape. This same finding is shown in a Cochrane review looking at all types of surgery, so other general surgery, orthopedic surgery, that show that there's actually a slight increase in infections with the adhesive drape. Now, do I think that we need to go and throw out all of our adhesive drapes and not use them? Probably not. But I think it probably comes back to the prep that we do. Now, I know that here we prep really, really well, but I can imagine what it's like at lots of other places, and I've seen other people prep. And our nurses are wonderful and save us lots of time, but I've occasionally seen preps from the xiphoid to just barely onto the upper thigh, and then you're sticking that drape on and unsticking it, and I think you're probably recontaminating your incision in lots of cases. All right, so now we're to the incision. We've given antibiotics, we've prepped, we've draped, now we're going to make the incision. Our first choice is, are we going to do a vertical incision or some form of a transverse incision? This has been studied in one prospective trial, wasn't randomized, where they just looked at all of the C-sections that were performed in Scotland and compared the outcomes. So this is what they looked at. They looked at vertical versus low transverse. Again, wasn't randomized. Their primary outcome was wound dehiscence significant enough to return to the OR for closure. So pretty significant dehiscence. And they found that for a vertical incision, the percentage that opened up was about 3%. For a low transverse, it was about 0.3%. So a significant difference. We don't have any randomized trials, but expert opinion, I think most of us would probably agree from having done both types of incisions, that there's less pain with a transverse incision, an improved cosmetic result, and increased strength with that type of an incision. So most of us are going to make a transverse incision in most cases. Now we have to decide, are we going to make this Joel Cohen type incision that's a little bit higher, or are we going to make a fan and steel incision? There's a Cochrane review that looked at this. There's only been 2 trials that compared just these 2 things, just the type of incision. The Cochrane review, these are the results that they concluded, that a Joel Cohen incision was associated with less pain, less fever, less blood loss, and shorter surgery, when everything else was held constant. Now, when I read this in the Cochrane review, I found this a little bit hard to believe, that moving your incision up 2 centimeters means less pain, less fever, less blood loss, and shorter surgery. So we've talked about this lots of time as residents, that our meta-analysis or Cochrane review is only as good as the primary literature that it's based on. So let's pull, it's only 2 studies, let's look at both of them. This is the first one, and the much better study. So in this study, it was out of Switzerland. They randomized to a Joel Cohen or a fan and steel incision. And they did the study really well. If we look at some of their outcomes, here first at the top, the Joel Cohen, they had 152, the fan and steel 158. This is the biggest study we have. The other one only had 50. So they're not huge numbers, but this is where we're taking it from. And they randomized these patients, and they described their technique really well, that other than the incision, they kept everything else the same. And they worked really hard to make sure that everything else was the same. And this is what they found. Essentially, as we go down the list, nothing was different except for the extraction time or incision to delivery of the baby. That with the Joel Cohen technique, it was a little bit faster, 45 seconds faster. They have a second table that looks at additional outcomes. So blood loss, fever, how long were they in the hospital? Nothing was significant all the way down. So what they concluded, I think appropriately so, is that there's not enough evidence to recommend performing a Joel Cohen incision over a fan and steel incision. So if this, our better trial of 150 patients in each arm, made this conclusion that they're the same except for extraction time, how did the Cochrane review come up with these other things that I don't think are true? Well, it came from this other study. This other study had 50 patients in each arm. And if you go through and read this study reads like a comparison of package techniques. So a comparison of the Fan and Steel to the Joel Cohen package. The methodology of it's sort of interesting. It was in India. They had a bunch of residents. They were all doing the Fan and Steel incision. They taught them the Joel Cohen technique. And then they said, we're going to do a study and we're going to time you. And we're going to do all of these different things. And they don't talk about the methodology at all, about how they kept everything else the same. And so when you look at their results, everything's significant, all the way down the list. So they said there's less pain, shorter surgery, less bleeding, less fevers, which are the exact 4 things that we saw were better with the entire Joel Cohen package, right? We already talked about that from the beginning. What I take from this study is that this was 50 patients in each arm, that they did a package technique, not just the incision. We have our better, larger study that said that other than extraction time, there really was no difference between the two. So what do I take from all this? What should we be doing, a Joel Cohen or a Fan and Steel? I think based on limited evidence in these 2 studies we have, that there's not enough of a difference to recommend a higher incision. And so if the only difference is extraction time with no difference in outcome for the babies, which they also showed, I think that we should choose the cosmetically better incision, a lower incision. They also talked about in their text that the Joel Cohen incision, when they measured them, were 17 centimeters on average, and the Fan and Steel was 13. So I also bet that if we were to go and do it ourselves, just learning a new technique, we'd probably be just the same with a Fan and Steel or a Joel Cohen based on what you've been trained to do over and over. So at this point, I find no reason to recommend the Joel Cohen incision over the Fan and Steel incision. As we go on, if you look at your handout again, the next 6 things on this handout, so how you dissect the subcutaneous tissue, fascial entry, fascial extension, dissecting the rectus muscles, peritoneal entry, and stretching everything to the width of the skin incision, none of these things have ever been studied in a separate randomized controlled trial. So what do we do? Well, when we think about it, on here we have all sharp versus all blunt. And we know that the Joel Cohen, when we compare an entire package, that blunt is better than sharp. And so I tend to think that where we have limited evidence, it's probably reasonable to take a minimalist technique and do what's blunt and what's easier. And so as we go through this, we'll talk about how it's described in packages but never studied in a randomized technique. So dissecting the subcutaneous tissue, your options are sharp or blunt. As we go through the fascia, essentially it's the same thing. Dissecting off the rectus muscles. So I know we do this a lot, and on here, all of the other packages at rectus muscles, none of them took them down. So they didn't put coker clamps on and dissect off the rectus muscles. And their patients did fine. In fact, when we compared packages, they did better than the sharp dissection technique. So omitting this in all of these studies has cast some doubt on the necessity of dissecting the rectus muscles off without any randomized studies looking specifically at that. Same thing with peritoneal entry. Our options are sharp or blunt. Most people would favor a blunt dissection high up in the abdomen, as far away from the bladder as you can be. All right, the next big topic is the bladder flap. So we've gotten back to something where we actually have studies. Initially, the bladder flap was created, it was a layer that was created so that it could be closed. And the idea came prior to IV antibiotics to have an additional layer to close over the hysterotomy, hopefully to prevent infection. And then, once we had IV antibiotics and we didn't really need it for that, it was continued because the idea was that it's protecting the bladder. If you take the bladder down, it's out of the way, you're not going to injure the bladder. We have a few studies that have looked at this. So the first one is a study entitled Urinary Tract Injury During Cesarean Section. What they did, it was a retrospective review. They looked at 7,500 patients that delivered at USC over about 5 years. And their question was, in the patients that have bladder injuries, what led to them? What happened in these C-sections that they got a bladder injury? And this is what they found. The most common time that the bladder injury occurred was displacement of the bladder base during repeat cesarean section. In their text, they described that displacement of the bladder base means creating the bladder flap. And their second one was displacement of the bladder base during a primary C-section. So that's 10 patients. So most of the patients out of these 7,500 that had a bladder injury, it actually occurred while they were creating the bladder flap. Now, I know there'd be questions at the end if I didn't say it. I'm not proposing that if in these cases they had not taken down their bladder flap, that they would not have had a bladder injury. We have no way of knowing that. I'm simply saying that We also don't have any evidence that taking it down protects the bladder, and we know that at least some injuries, in fact, most of them from this study, happen while taking it down. So I had this study up there at the beginning. This was the description of the Pelosi technique compared to the traditional C-section, and when he described his technique, he didn't take down the bladder flap. A study came out after it that in the introduction referenced the Pelosi technique and said, well, they had their technique and they didn't take down the bladder flap, so we're going to do a prospective randomized trial and see what happens. What would the difference be if we didn't create a bladder flap? This was published in the Green Journal in 2001. Table 1 is their demographics. So they randomize their patients well. Now, again, this is small. It's only 50 per arm, but this is the best study that we have looking at this. This picture describes what they did. So in one group, they created a bladder flap like normal. In the other group, they didn't. So in the group where they didn't, they made their incision up just above this dashed line. So the dashed line represents the vesicouterine peritoneal fold, and they made their hysterotomy about 1 centimeter above it. And they included this picture, and they said, when we did this, in this case, they didn't take down the bladder flap. They said it looked the same. When we were done, the bladder descended on its own and fell out of the way, whether we created the bladder flap or not. So they took a picture and put it in there to say, look at this. This is not creating a bladder flap, and this is what it looked like. And what did they find? Well, they found 4 things that were significant. So their study group is the group where they did not create a bladder flap. Their control group is where they did. The first thing was incision to delivery time, 2 minutes faster in the group where they didn't create a bladder flap. Total operative time was about 5 minutes faster with no bladder flap. The bleeding was less, and their pain meds, they based on how much they required on postoperative day 1 and 2, was less. They had less pain. So while it's small, even with these small numbers, they were able to see a difference, that it was better to not create a bladder flap. So what did they conclude? No bladder flap is faster, less bleeding, and less pain. To have a study that would assess whether this increases our risk of bladder injury or not is nearly impossible to do. So the rate of bladder injuries is so low, about 0.3% of all C-sections, that it's estimated that to show a difference in bladder injury, if there is or not, would take over 40,000 patients randomized. We're never going to have a trial that's that big. So let's move on. Our next option, we're making hysterotomy, and our choices are to do a classical incision or a transverse incision. And I don't want to go into this in detail. We know the benefits of a low transverse incision. We've talked about the rupture risk. This could be a whole nother grand rounds. In most cases, you're going to try to do a low transverse incision if you can. The real question is, once you've gone through and you've started your hysterotomy, how are you going to extend it? So are you going to do this sharply or bluntly? Are you going to use bandage scissors, or are you going to manually expand your incision? We have 3 randomized trials that look at this, and this is the largest and best of them, I think. So this study randomized 470 women essentially in each arm, 1 to sharp dissection, 1 to blunt expansion. And this is what they found. I marked what was significant. So we have the sharp column and the blunt column. Their first 4 things up there essentially are different ways of measuring the blood loss. But in all of them, the ones that I highlighted are the ones that are significant. All of them, in the blunt dissection, there was less bleeding. And then probably the most interesting one is this extension, or when they had an extension. So a small extension, 1 to 2 centimeters, 57 in the sharp versus 20. Or a big extension, greater than 3 centimeters, 69 versus 24. So they concluded that there's less bleeding and less extensions, unanticipated extensions, if we do a blunt expansion. How are we going to do it? This is also a really interesting study published in 2008 that looked at the method that we use. This was performed in Italy, and they compared 2 different techniques. So one of their techniques was the traditional technique where you place your fingers in and essentially pull laterally and slightly cephalad. And then the second one, or B, they actually put their fingers in and they separated and pulled in a cephalad-caudad direction to do this extension. Now, I remember my intern year when I saw this done one time, this technique over here, during a crash C-section, and I made the hysterotomy, and then the attending that I was with stuck his fingers in and tore that way, and I thought he was tearing a classical incision into our hysterotomy. Well, it wasn't. It worked great. And so they studied this. Which is going to be better between these 2? And they found that this caudad-cephalad, or cephalad-caudad group was actually better. So there were 3 things that were significant. Again, they looked at unintended extensions, and they had about half as many in that group. They looked at the need for additional stitches, 30% versus 20%, and significant blood loss greater than 1,500, 2% versus 0.2%. We'll come back to this in a minute. So now we're to delivery of the baby. We're going to deliver our baby. I don't have any randomized trials about this. You're going to pass off the baby. Now we're essentially halfway through this talk. So now we've delivered the baby. Now we have to work our way back out. The first thing is delivery of the placenta. So when we deliver the placenta, we have two options. We can do a manual extraction, reach in and take the placenta out, which I personally think is one of the more fun things to do during a C-section, or massage on the fundus and traction on the cord. It's been studied in a lot of studies. 15 randomized trials with almost 5,000 women in a Cochrane review published in 2008 that tell us that traction on the cord is better. So the things that I wrote up here are manual removal, so reaching in and pulling the placenta out, is associated with more endometritis, greater blood loss, and a longer hospital stay. So between these two, we really should be massaging the fundus and with traction on the cord. What about exteriorizing the uterus? Should we sew with the uterus in or out? There's been 9 different studies looking at this, and it showed no difference, which I was glad that it showed no difference because I hate sewing with it in the belly. But no difference between the two, so provider choice. You can do whichever one. When they looked at it, the first 6 showed that, and then when you combine the last 3 with it after the Cochrane review was written, they showed no difference. How about cleaning out the uterus with a lap? Never been studied. All right, our closure. So another big topic, single versus double layer closure. This also could be a whole grand rounds. So there was a Cochrane review published in 2008 looking at single versus double layer closure. And they concluded that essentially single layer closure is better in terms of blood loss, the length of surgery, and the amount of pain that they have. So they bleed less, they're done faster, and there's less pain after with a single layer closure. But they only looked at short-term outcomes. So if you're just thinking about short-term outcomes, it's probably better to just do a single layer closure. Now, I know everyone's thinking, that's wonderful with a single layer closure, but what about our risk of uterine rupture down the road? There's only been one prospective trial looking at this. They took 900 women, and they randomized them to single or double layer, then they followed them. And 164 of them came back to the same university, University of Alabama, and had a subsequent delivery. And of those, 19 had a repeat section, 145 underwent a trial of labor. So this is the biggest prospective trial we have of 164 women. And what they find between the two different groups, well, we have our 1-layer and our 2-layer closure, and they couldn't find anything that was significant. They did, the last line down here, have 1 uterine dehiscence. 1 in the single layer, none in the 2-layer, obviously not significant. So where do we get this from? Where does our evidence come from to do a double-layer closure? It comes from 2 other trials. One of them is an observational cohort study that was done in Quebec, Canada. They looked at 2,100 women undergoing a trial of labor, and of that group, they diagnosed 23 uterine ruptures. And then they went back to say, what are risk factors associated with uterine rupture? And essentially, they found one thing. So the one thing they found, which is highlighted, was a single-layer closure with an odds ratio of 3.4. So this was based on 23 ruptures. There's one additional paper, actually published by the same author, 2010 in Obstetrics and Gynecology. This was a case control study. They took 96 ruptures, and they compared it to 288 controls. And what they find? Essentially the same thing. So there's one other thing on here that's significant, just to point it out, and the size of the baby was also significant. But what's highlighted? Single-layer closure with an odds ratio, an adjusted odds ratio of 2.69 for uterine rupture after a single-layer closure. So all of this data that we have, all this evidence that we have for doing 2-layer closures comes from these 2 studies, one with 96, one with 23. We may get some better answers in the future. So this is, I found an abstract for this, but the actual paper is not published yet. Recruitment for this study closed in January. They took almost 16,000 women, so a really large study. And they recruited enough, they needed this many because they actually were randomizing to 5 different C-section techniques, and they're hoping to be able to show a difference or not between all 5. So these are the things they looked at. Blunt versus sharp abdominal entry. Should you exteriorize the uterus or not? Single or double layer closure. If they're going to close or not close the peritoneum. And the last one is chromic versus vicral, which will be interesting. I had several people ask me as I was saying that I was going to do this presentation, is there a difference, chromic or vicral? We don't know. But maybe we'll have it at some point in the near future. Next one is closing the peritoneum. So should we close the peritoneum or not? This has also been reviewed in a Cochrane review with 14 trials and almost 3,000 women. And what did they conclude? That non-closure, or leaving the peritoneum open, is faster, there's less fever, shorter hospital stay, less need for pain meds, and a trend towards less wound infections. We have really good evidence. We should not be closing the peritoneum. That should not be a part of our C-sections. And we're not the only ones that have noticed that. So this was a paper in 2003, which was published in the American Journal of Obstetrics and Gynecology. It's out of Canada, and their intro's sort of interesting. It asks the same question. It says that they essentially came to a meeting, they looked to see what was happening, and they saw that many gynecologists, so this was actually from GYN procedures, still considered closing the peritoneum to be a necessity, and to fail to do so is poor surgical technique. And then this paper goes on and talks about why you don't need to close the peritoneum, all the reasons. They talk about animal studies, that in animal studies, if you leave it open, it heals in an average of 5 days. If you close it, complete healing takes approximately 2 weeks. When they looked at studies done in horses, actually, non-closure was associated with less adhesion. So if you closed it, you had more adhesions. We have 2 studies that have followed women who have had their peritoneum closed or not, and then that have gone back to surgery to look and see what happened. And in this group, non-closure, so the ones that had their peritoneum left open, that had a subsequent C-section, actually had a shorter incision to delivery time. When they looked back through the documentation for adhesions, they found no difference that was documented. But you would suspect that maybe leaving it open is a little bit better from an adhesion standpoint, but at least it's not worse, and no difference in fertility pain or urinary symptoms. How about irrigating? There's lots of published studies on irrigation at the time of surgery or C-section, but most of them were done prior to IV antibiotics when they were actually irrigating with antibiotics in the fluid and comparing and saying that it's better. Studies since then, we don't have very many. There's one study that was randomized that looked at irrigation specifically with C-section. It's not that big, had about 100 in each arm, but if you look over here again, nothing was significant. So this group they irrigated, this group they didn't. They looked at a whole bunch of things, blood loss, infection, hospital stay. It's all the same, whether they irrigated or not. There's some studies in the general surgery literature, not a lot. There's other animal studies, but from all of the studies, it looks like unless you have a frankly infected wound, that there's no difference. Clearly, if you have frank infection or if there's pus, then irrigating is going to help. But shy of that, in a setting of IV antibiotics, it doesn't look like there's a difference whether we irrigate or not. Now, if you do a crash C-section and you don't give antibiotics or you don't prep, of course irrigate. But if everything's like normal and you have a sterile field and they've gotten antibiotics, it doesn't look like there's a difference between the two. So you've given this big stretch on the rectus muscles before. Are you going to put them back together? We don't have any randomized trials looking at this. Expert opinion would say that they find their own way back and that a stitch may hurt more, but we don't have any trials that specifically look at it. How about closing the fascia? No studies specific to a C-section. We have lots of studies in the general surgery literature, and essentially what they compared is rapidly versus delayed absorbable sutures and continuous versus interrupted. And what did the study say? As you would suspect, that we should be using a delayed absorbable stitch. They didn't find any difference between interrupted or continuous stitches, although they did find that continuous was faster. Irrigating the subcutaneous tissue. We have one study on this, 160 women, randomized to each group. Irrigate in one group, don't irrigate. There was no difference between the two. I think it's probably the same as before with intra-abdominal irrigation, that with IV antibiotics, it probably doesn't make any difference. Now, we're ready to possibly close our subcutaneous tissue. So I know we've talked about this a lot. I think anyone here can quote the 2 centimeters that should be closed or not closed. But where does this come from? It comes from 6 prospective trials, and then this, which is a meta-analysis looking at all 6. They broke it into 2 different groups. Their first group was wound disruption, and they defined wound disruption as essentially any problems with the wound. So seroma formation, hematoma, did it open, was there a wound infection? And for a depth, there were 2 studies that looked at a depth less than 2 centimeters, and for those, there was no difference. Didn't matter whether you closed it or not, it was the same. They then had 5 studies where they closed a wound that was deeper than 2 centimeters. And they did find a difference for this. So the relative risk here is 0.66, favoring, as we move this way, favoring treatment or closure of the subcutaneous tissue. I think the important number to remember is this one. Our number needed to treat is 16. That's pretty good. Close 16 wounds to prevent 1 wound disruption when it's greater than 2 centimeters. Now our last topic is how do we close the skin? Staple or sew? And of course this has to be last because there's so much controversy over what we should be doing. In fact, there is an article in the Green Journal from this month, which many of you have probably read, that looked specifically at this. It was a meta-analysis, staples compared with subcuticular suture for skin closure after cesarean delivery. If you read this, it looks like we should be sewing everybody, that stapling's terrible. So I wanted to go back and look at the literature from this one too. So what were the studies they included? They had 6 studies. The first one is a study from about 20 years ago that was really small, had about 25 in each group, showed no difference. The second study they included wasn't randomized. They included 4 recent, large, randomized trials. So all of these were published after 2008, and they all looked at stapling versus sewing. Let's go through them. The first study is right up here, top left. This is a study out of Switzerland that looked at 153 patients. Their primary outcome was scar appearance at 4 months. So what did it look like at 4 months? And this is how they reported it. They had a few extra groups because if you look here, they included also subcutaneous closure. So whether they closed the subcu and the skin and how they did it, 4 different groups. The important point is there was no difference. It looked the same. This was the patient and an observer looking at it 4 months saying, which looks better and how satisfied are you? No difference between any of those. The second study, so the top right, this is a study by Rousseau. This one, they took digital photos of the incisions at 6 weeks and sent them to 3 blinded observers to compare them. They also, this is the only study where they attempted to blind the patient. So they put a dressing over the incision and they tried to keep it blinded at least for the first 2 days while they were assessing pain between the 2 different incisions. And what did they find? Well, as you would expect, operative time was less in the staple group, and about 8 minutes less. So to staple is faster, and at their pain, there was no difference on day 1 or day 3. At 6 weeks, the staple group had a tiny bit less pain. It was significant. Is this clinically significant? 0.5 versus 0.2 on the pain scale? Probably not. But they were able to show a difference. At least staples weren't worse in this study. They also looked at the scar appearance. So these were the blinded observers that they mailed the pictures to. The scale up here doesn't really matter. The point is they looked the same. They couldn't say that one was better than the other. Our third study, published in July of 2010, looked at 3 different types of closure, 3 different ways of sewing essentially, and then 1 staple group. And their outcome, again, their primary outcome was appearance. So these are 4 different methods of assessing the way a scar looks. And they found no difference. They all look the same. So whatever of these subcuticular sutures, they did 3 different types, or staples, it was all the same. It didn't matter. So where does this difference come from? From the Green Journal article where we say there's more breakdown of these incisions? It comes from 1 article. It comes from this 4th article published in September of 2010. In this study, they randomized 435 patients to staples or suture, and they followed up by a telephone call. So I think the details here are really important. They called them, and they talked to 95% of the women down the road, and they asked them, did your wound separate? And so their primary outcome was wound separation, and it was defined by any separation that the patient identified. So they said, did your wound separate, yes or no? And if it separated, then they got in the separation group, and no, then they were in the no separation group. And this is what they found. So the first one, the composite wound, which is up here, is a combination of these next 3. So did they have any wound complication? Things that they found that were significant were a significant number of wound separations in the staple group. 17% versus 5%. Did they have a follow-up visit? That's this here. So what's really important and really interesting, and they comment on in the text, look at this. Office visit for staple removal, 25%. And in their text, they say, we don't know why this happened because this isn't our usual practice. We always take staples out before they go home. And for some reason, 25% of our patients had their staples out in the office. There's something different between these groups and something different from the normal technique that they were typically doing. I think this next slide and their next chart from their paper is the most important of all of them. So this looks at, okay, so there's more separations with staples. At least it appears from this. What did that mean? What happened with these separations? Let's look at the biggest number. So we take the staple group. We take all the ones that had a wound separation. 42%, the highest number. What did they do? They closed it with a steri strip. So I think everyone here, at least I've done this at least 50 times, been called to the postpartum floor with a nurse that's taking out staples that says, I think her wound's opening up. and you go look at it for 1 second and say, it looks fine, put a steri strip on it? Because it's not, I mean, is it a separation? I guess. Would the patient, when you call them on the phone later, say, did your wound separate? Probably. But is it a clinically significant separation if you can close it with a steri strip? I don't think so. How about this up here? The second biggest group, 30%, secondary intention and no packing. That was what happened with most of their patients. They either put a steri strip on or they just left it open and it closed on its own. So let's look. This is the article published in the Green Journal, and these were their findings essentially. So wound infection, they combined all 6 of these studies. These last 4 are the ones that we just went through, all of them, and they found that there was no difference in wound infection. This is looking at wound separation. So did your wound separate? And they found that it was significant. We had more separations, so this side favors sutures, more separations if we sewed, or excuse me, more separations if they stapled, with an odds ratio of 4.2. You got to notice, though, where does the weight of this come from? It comes from the one study that we just talked about. So we know this is probably true. We probably do have more separations if we staple. But the important thing is it a clinically significant separation that goes up? It doesn't seem like it from looking at the primary literature that they take it from. What about the time? So they combine all their studies. Staples save an average of 3 to 9 minutes. And finally, hopefully this can finally be put to rest by combining these. Is there a difference for the patients? Pain score, combining them all, equivalent. Satisfaction, equivalent. Cosmesis, equivalent. No difference in those. So really the only thing we see, staples are faster, maybe some small separations that go up when we staple. So to finish, I want to go through really fast, start to finish, through a C-section, and talk about, after reviewing all this, what do I think the best technique is. So clearly we're going to start and we're going to give antibiotics, and we should give it before surgery. We're going to prep with something. If you have a choice of both, a chlorhexidine prep is probably better. We're going to drape. If you have both drapes sitting there, don't grab the sticky drape because you think it's going to reduce infection. It may actually increase infection. At least prep really well and drape with something, and the sticky drape may actually be a little bit worse. When we make our incision, so our choices are the fan and steel or the Joel Cohen incision, I'd choose a fan and steel incision. I don't think I see anything from reading through this literature that would suggest that a Joel Cohen incision is better. Maybe it's a tiny bit faster to deliver the baby, 45 seconds. It's hard to think of many cases where 45 seconds is going to matter. And if you can have a cosmetically better incision, that's what I would choose. My first one, skin incision, is the fan and steel incision. Once we've gone through the skin, what are we going to do with the tissue while we're dissecting down to the fascia? We can either go through sharply or we can go through bluntly. Like we talked about before, there's no randomized trials on this, but I think that when we have limited randomized trials, we have to go back to our big review of the package techniques and say, if we're comparing sharp versus blunt, which one wins out? We know blunt wins out from 23 different studies. So when we get to these steps where we don't have anything, gosh, I favor the blunt dissection. So for this, I would say sharpen the midline to get down to the fascia and blunt the rest of the way. How about our fascial entry? Our choices are essentially to go through first with the knife or with the bovie. It'd be hard to think of a way to do it all bluntly. So I'd go sharp. I think you could probably use the bovie and that'd be fine. The real question is extending the fascial incision. So what are you going to do once you've gone through? In this case, again, I'd favor a blunt dissection rather than a sharp. So rather than elevating and using your curved Mayos, blunt dissection. When we get to the rectus muscles, we know from looking at the package techniques that these patients do fine when you don't dissect off the rectus muscles. So we don't have any randomized trials, but we know from a lot of studies that they do just fine. In fact, considering the entire package, they do better. And so in this case, I would again propose that we bluntly separate the rectus muscles, that we don't put coker clamps on and dissect the rectus muscles off. There doesn't seem to be a difference. If we get to the point now, so now we're going to make our peritoneal entry, again, I would go with blunt dissection through the peritoneum. Are we going to reach in and stretch everything? Yeah, I think that's the right thing to do. So then we get to the bladder flap. Unless the bladder is scarred high up on the uterus and there's no way to make the hysterotomy without taking it down, I don't think it's necessary. We have a few small trials that say that it's better to not take it down. We know that a lot of injuries happen when you take it down, and we have no trials to say that taking it down is helpful. So with no trials saying that it's better, I would propose that unless you have to take it down to make your hysterotomy, it's not necessary. So I'd fall over in this final Pelosi technique, no bladder flap. Once we've made our hysterotomy, then we're going to expand our hysterotomy. We have the two different techniques. We can do it bluntly, and I think not just bluntly, I think we should do it this direction. So pulling towards her head and feet, or an cephalad-caudad direction. So blunt dissection, but not just blunt, using that second technique as well. When we deliver the placenta, we should do cord traction and fundal massage. Even though I like the other, I think this is better. Exteriorize the uterus, it doesn't look like there's much of a difference between the two, so surgeon preference. Cleaning out the uterus, it's never been studied. I bet if it was studied, it'd show no difference. I think I'm probably going to continue to because it'd be really embarrassing to go back for retained products after a C-section. Closure of the uterus. So from our Cochrane review, we know that for short-term benefits, a single layer closure is probably better. So if you're doing a tubal or if there's minimal risk of labor in the future, it's probably okay, probably even better to do a single layer closure. But I still think, even though it's based on small numbers, 23 patients and 97 patients, if we think they may labor, or even if they're going to be pregnant in the future, it's probably better to do a double layer closure. So 2 layers of continuous suture. Irrigation. We have very few studies, but the studies that we have suggest that it doesn't make any difference in an era of IV antibiotics. So I would propose skipping the irrigation step. Closing the peritoneum. We have really good evidence on this, that we should not close the peritoneum, that patients do better when we actually leave it open. So peritoneal layers, don't close. Closing the fascia. It's really just from the general surgery literature. I don't think there's much argument that we want a delayed absorbable stitch. So I put on here continuous suture, use something that's delayed absorbable. Closing the subcutaneous tissue. We looked at the studies, the Cochrane review, or the meta-analysis we went back through. If it's greater than 2 centimeters, there's good evidence that we should close it. Number needed to treat's only 16. So Pelosi was the only one that talked about this, and he said close it if it's thick. And I think that's the right thing. If it's 2 centimeters or thicker, we should close the subcu. And our skin incision, I still think we should staple. It's faster, 3 to 9 minutes faster. And I bet it's even faster at a training institution. I bet it's way faster than that, than doing a subcuticular closure. So just for our flow on labor and delivery, this saves so much time to staple. And we went through the evidence. I think that the wound separations we have are really small, probably clinically insignificant wound separations. I would propose, in my technique, that we staple. So I come back to the initial question. If Joel Cohen can have a technique, why can't I? Why can't we come up with our own technique? The nice thing is we're not forced into one of these things. Now, if you were forced, if someone said you had to do just the fan and steel technique or just the Joel Cohen, you'd probably be better off choosing the Joel Cohen technique. But we don't have to. You can pick and choose what you want. What's the best of each one? The combination can give us the best C-section that we can perform. Now, I know C-sections are common. It's the first thing we learn as interns. They happen all the time, but that's why they're so important. There's 1.3 million of them a year in the U.S. alone. So little tiny changes can make a huge difference. If we can cut down the infection rate by 1%, multiply that by 1.3 million, that's huge. If we can save 5 minutes in the OR times 1.3 million, that's a ton of savings. So I think that while C-section may get passed up because it's a simple procedure, it's important just because it happens so often. And to conclude, I want to thank Dr. Clark for her help, and Dr. Silver and Dr. Parrott for letting me show up in the OR with a camera and didn't complain at all. Thanks.
Questions?
Yes.
Did you find any data about putting a drain in the subcutaneous layer when they're really thick?
Yeah, it doesn't look like it's helpful from what I could find. It hasn't been studied that well. Most of the studies were on closure of the subcutaneous tissue. Yes?
Are any of your blood injury recommendations affected by it being a repeat section as opposed to primary?
Yeah, I think that's a really good question. Certainly, as you look down this, and if you were to do mostly blunt, there would be blunt dissection that would be much more difficult during a repeat section. And I think we've all tried blunt dissection in a repeat and had it be hard to do. I guess the point that I would make from going through this is that blunt is probably better than sharp, but obviously we have to adjust to every situation that we're in. So if you're doing blunt dissection and you don't get enough room, then you have to move on to sharp dissection. Just like the irrigation. If it's not a clean case and you didn't give antibiotics, well, of course irrigate. So same thing with the blunt dissection, that it's probably better to start that way, and there's lots of repeats where you could do most of it with blunt dissection, but if it doesn't work, then you have to move on to whatever you need to make enough room to perform the delivery. Mm-hmm.
I just wanted to read those articles, if you know, with the rectus muscles and with the stretching on the uterus.
Yeah.
It looked like they were just using 2 fingers. Is that what it looks like? And I see a lot of people put like the whole hand to do the up and down. I just wonder if that's right or wrong, because I just can't.
Yeah, the picture does show 2 fingers. And I've done this several times, especially after reading this, trying the up and down. And I found that after, at least for me, the size of the hysterotomy, it usually fits 2 fingers perfectly. But they didn't talk about it during their paper at all. They didn't say whether they did 1 or 2.
They just say to hold to the side.
So the rectus, yeah, when they described it in these techniques, they essentially describe an up and down stretch and then a lateral stretch just to make enough room. Mm-hmm. I don't have a comment on it. Some of those studies took all comers. So they included crash C-sections and showed that there was still a bet. I don't know that they limited their analysis just to that group, but they did include them in their analysis. So I guess I don't have anything specific to whether you should leave them out if it was a crash C-section.
Question. So not so much here, but in a lot of areas of the country, they're aggressively marketing adhesion barriers to be placed at the time of C-section. Did you come across any of that literature?
Yeah. There is not, I was going to put adhesion barriers in the talk actually, but then it ended up being a huge topic to address. And they certainly are marketed all over. So interseed and Ceprafilm are sort of the 2 that are talked about. There's only been 2 studies on C-sections, and when they were both really small. When they looked at their patients, I think one of them had like 8 patients and the other one had about 30. And it does look like using an adhesion barrier cuts down on adhesions. The real question comes from, what does that mean long term? So if you, with the repeat section, they take about 5 minutes longer on average with no difference for the outcome for the baby. And so we know that even though there's adhesions, it's usually not a significant problem. In the general surgery literature, they've looked at a lot with bowel resections, and they found that some sort of adhesion barrier cuts down on the postoperative bowel obstructions from about 3% to 1%. And that's their main outcome that they found, which is great, that they can cut down on bowel obstructions. With C-sections, though, a bowel obstruction you have to return to the OR for is so rare and almost never happens that if that's the primary outcome that we look for, they, at least in one study that I read, they estimated that we would have to spend somewhere between $300,000 and $1 million on adhesion barriers to prevent 1 bowel obstruction. So we definitely need more studies, and it looks like it probably cuts down on adhesions, but whether that's significant in any way, it doesn't look like it, and it probably costs way more than it's worth. Yeah?
Speaking of huge topics, if you have a patient that's obese, super obese, morbidly obese, has large penis, did you find any data about doing a fascial incision underneath the penis, doing a vertical incision above the penis? And is there any data about the different techniques that we use to elevate the penis? And you know anything about this Alexis O, and has it been studied?
So I guess I would have to say no to all of those things, unfortunately. I didn't specifically look for the incision that we use, and I also didn't look at the Alexis O literature. Yeah.
Did you look at anything about skin closure?
No, there's a different skin closure technique that's totally different than any of these that we talked about. The Mizgavlatic technique, they used mattress sutures and put on 2 Alice clamps and left them in place for 5 minutes and didn't sew or staple. That's sort of an interesting technique. But specific to Dermabond, I didn't find anything that talked about it.
That was a great review of the literature. And I would just second that, in cases where, in situations where we don't have evidence of benefit with a technique or a procedure, and we don't have evidence of harm with omission, I would really encourage a minimalistic technique. Time is money, and time is safety. On our labor and delivery, as in labor and deliveries across the country, we have limited resources. And the faster you can safely complete a C-section, the faster those medical providers in that room are available for other patients. So where there's lack of evidence about something and no evidence of harm with omission, a minimalistic technique, I would argue, is best. Well, that was great.